Let's continue with our coverage of the NHI Bill, set to be signed into law this afternoon. In fact, in about 25 minutes' time, President Cyril Ramaphosa will take to the podium at the Union Buildings. He'll give a keynote address. There'll also be a Q&A with the Health Minister. But let's bring in Professor Shabir Moosa from Wits University. He's also a family physician and runs the Chiawelo Community Practice. He joins us for a discussion on NHI. Prof, it's great to see you. Thanks very much indeed for coming in.
And thank you to you viewers.
I think the easy question, which we've been discussing off camera for some time, is are you a proponent of NHI?
Yes, I am. I think it's a great piece of reform. I think it's important, and we can get into the details of that. I don't think concerns being raised are unimportant.
Right.
I think anything needs good public consultation. I think the difficulties I have is actually how long it's taken to get here. From the time we heard of it in 2008, I mean, for 16 years for a piece of legislation to be implemented, I think that is not overdue. You know, it is overdue. It's something we just need to get on with. Some people just talk about things like, you know, oh, there's not enough money. And hang on, was there budgeting, you know, planned exactly for this? If anybody looks at the, you know, I put it up on my website, profmoosa.com, how the NHS started. And it was literally within 2 to 3 years that from inception to actually implementation, where it was literally said, there we go, start. Literally what the Premier of Gauteng did, you know, on that day, go to the hospital and you'll be taken care of. And that was done in the UK. And, you know, yes, it did need more money as it went along, and there were challenges with it. But, you know, some of the discussions today are overly complicated. And you know, I think in a world, we obviously have a more complex world, but sometimes things get overly complicated.
Let's talk about, because you ran what was essentially a pilot project. Is that fair to say?
Yes.
At Chiawelo Community Practice.
That's right.
So what did you do differently during this pilot project that you weren't doing before?
Well, let me give you some background, because that'll help you to contextualize that. Essentially, I was appointed and came to the public service to see what I could do, make a difference in 2004 as a family physician, to say, you know what, there are not enough doctors in the public health system. Let's find a way to attract more doctors, make them feel welcome, and make them work in teams that would address population care as the public mandate requires. And in doing so, I found in my experience of the public service that yes, there's serious challenges. But when I think about it, in 2004, when I came, was actually the year in which the National Health Act was implemented, which you think about it, you know, that's 10 years to take to actually build up what a national health system looks like. Understood, you know what, we had a constitution first, and then we had to have local government, then we had a district health system that's captured in it. So, you know, it was a new system. Took time to get going. But it's gone its distance, in the sense that, you know what, immediately government said, we want to try and make sure universal care is there, and they said, there's the package. It's based on a nurse with the support of a doctor. Populations, and that's why I came around, the population said, we're not happy, we want a doctor. You know, otherwise and then they were going to the hospital. So we tried to do that. But there were natural problems within the management capacity of the district health system. And in fact, the fact that many doctors were being stolen away into the private sector. So in a way, it was difficult to implement a lot of the quality that one wanted. I'm not saying that the public service implementation is not blameless. But when I heard about NHI, it was to say, and it was there right from 1997, when the white paper was announced, and in fact in the ANC documents prior to that. So they talked about this kind of national system, which is more similar to the UK, and that's what we're kind of looking at. But when I heard about it, I then did a study in 2011, looking at GPs and saying, how would they respond to this new concept called capitation? And capitation is moving away from a fee-for-service, where you go in, pay a fee and get a service, or budgets, which is what the clinics have right now. But this is paid per capita, per person, per year, and it's usually in a monthly. And then they get this, you know, adjusted somewhat for age, gender, etc. So I said, how will GPs respond? Because, you know, impending system. When I did that study with, you know, a sample of all of the GPs at the time in South Africa, we found that, you know, there was a bigger study and it's published, but one of the things that I found quite interesting was when I asked, what do you see as the risk with NHI? Firstly, the costing was incredibly cheap for the GPs. In other words, they were as competitive for that time, 2011, for the public service, which was like, this is really important. Three things came up.
So GPs won't be losing out financially, is what you're saying?
That's right. They were actually going to make more money with the capitation approach.
Okay.
Then we asked the risks and what would they mitigate these risks. Now, capitation has risks. So the first one they said, which was their point of view, which is said government's not a trustable partner. You know, understandable, they're not being paid completely in the system that is. How they would mitigate that is to have a very strong contract. The second thing they said is that what you posited as an assumption in the capitation of 3 visits per person per year, which is the average number of visits people will make to the service, which was halfway between 2, which is in the public service, and 4 in the private sector. So that 3 was a midway, but they said, no, too low. People will use it much more. And they actually suggested 6 and 8. Truthfully, that's a questionable thing, whether that number is completely right, that it'd be more or less. But what they did as mitigation, they said, we will do health promotion. Mm-hmm. Now, that's actually a very good response, because if patients come to the clinic too much, the way to respond is not to cut, which is a few doctors said they would do, which is limit access. They said, no, we'll try and keep them healthy, which is a great response. And that was mostly from young GPs at the time. The third thing they came up with, which I think is very important in the whole transaction, the process that unfolds, is they said, we are currently functioning with like 20, 25 patients in a small room. But based on the capitation contract of 10,000 people, which was suggested, and with the assumption of 3 visits per person per year, the number of 120 is a huge shift in paradigm, mm-hmm. which is true. You know, you're going to have to make people go through this process slowly, expand, adjust, because currently GPs are just used to saying, cough, cold, here's medicine, and bye-bye. They aren't managing the complete person in a more complete way that the public sector seeks to do. Mm. And in fact, that's good practice, largely because it's a fee for a service. So if you're not sick, why am I going to do anything? I don't get paid to give you education or to tell a community health worker to follow up or to do prevention or call you into a group. Nothing's paid like that. So you can't do things. And that's why globally capitation is seen as a much better payment for primary healthcare systems. Mm. So that's when I said, you know, great insights from the study. Let's see if we can see in the public service context, can we implement something like that?
But again, my question to you, Prof, is do we need NHI for this?
No, at the end of the day, I think very much so, because the big difference, and I'll come to that question, is that I then took the population. Now, the current public service functions with a very nebulous participation. In other words, you can go to clinic A, B, C. If you're not happy, you just jump around. Whereas capitation is about you are saying, I'm your GP, you're my GP, and I am going to be with you for 6 months or whatever. And then we will have a committed relationship. You get paid for me, and I come to you. If I'm not happy, I'll move to someone else. Payment goes to. Public service, not like that. Very, you know, you walk in, you're just a number. Yeah. Whereas in the private sector, it's a fee for service, so I just must get you to be serviced, and then you'll come more. Mm-hmm. So the more I create complications, the better it is for me. Now, in the public service, we then said, no, let's do this. Let's make a capitation-like, situation. So we went through a community in that area, and we actually enrolled people, and we got community health workers to do that in the community. Now, this is a particular model. In the NHI, I don't see that as necessary to be as complicated as that. But we were doing it in creating a model which was not there. So what we did is we did something that was practiced or developed in South Africa almost 80 years ago, in terms of trying to build in what we call community-oriented primary care. Right. Now, what I did was using that principle, but based on the fact that we have a population, not patients, population that is enrolled to this practice, but we're going to take one step further. We're going to see, can we, through looking after these patients, not just give them medical care, but actually find ways to manage the utilization down while improving quality. Because the utilization, the visit rate, is a cost. Mm-hmm. The more patients come through to use higher cost services, the more expensive it is. And we did that. But the principles were, one, community health worker is very core to that, to work in the community. There are other ways to do it, but in our townships, that's a very good way to go about it. The second thing we did is in the CHC, in the clinic where we set up in a corner of the community health center, the public service, we said, let's make sure that that community health worker is core to our whole filing system. So the filing system we did there, it's about the major difference. We had a family folder, individual folders, and a community health worker folder where when we see you, we're not just looking at what you have telling us. We're seeing what your home context has been picked up and your family. And then we just had simple appointment systems. So nothing complicated. And I think the point you say about the question you raise, I'll come to that question about do we need the NHI for it. The third thing is we engage with the people in that community to actually achieve this. And then the fourth thing we did was that based on the information, we then did very targeted health promotion. Now, the question you ask is, do you need NHI for that? And that's exactly why I actually gave up in the public service. And why, when I shared it and tried to go into the private sector to say, can we implement it, it didn't get taken. Why? Because the payment system doesn't drive this. And that is part of this whole strategic purchasing that should come to bear with the NHI. To say, let's give you the kind of payment system that builds up the right incentives. And this is what I'm talking about. Now, obviously, there are other systems for hospitals. I don't want to talk about it. In the primary care capitation and its blended capitation, global practice, best practice to use predominantly capitation with a blend or adjusted, and then a blend of some other payments that get into a mix. More complex, but keep it as simple as that.
Prof, we are running desperately out of time, but I want your take on two issues, two important issues that have been raised by critics of NHI. The one is that the appointment system is very concentrated to the minister. So he appoints the committees, he appoints the board chair, he appoints members of the board. The NHI is being sort of run by the existing PFMA. There's not, and it's relying on parliamentary oversight, which we know has failed us in the past. Insofar as those kinds of governance issues are concerned, what's your take on that?
Well, I'm no expert in governance, but having looked at the deliberations that have been going on, I think, firstly, people are talking about, the consultation, if I may just go back to that, as the consultation doesn't listen to us.
Right.
But we're a democracy, and in which the people of South Africa have chosen a government, and in which they have the authority as a parliament that represents, and next week is a chance of 2 weeks' time to go and change that. But it should be that the people of South Africa, represented by their representatives, make those decisions. I don't disagree with you. The minister needs to be held to account, but by no different a standard than exists in all our current structures of government. And we've been, an article by Olive Shisana shared that this is not a Section 3 or a Schedule 3 organization. It's actually not profit-driven. It's actually a different type of organization with a lot simpler organization. So I think we need to look at the practice in South Africa and not try to become alarmist. I think like the US, South Africa has got a huge amount of vested interest in the private sector.
Prof Moosa,
and I think that can evoke a lot of alarmism needlessly.
Listen, alarmist as it may sound, I think it's warranted, right, given the kinds of corruption we've seen in the healthcare sector.
You can't sort of upend the government and say it's got no right to rule.
Certainly.
So.
Prof, let me thank you for your time. Professor Shabir Moosa he runs the Chiawelo Community Practice, and of course he's a family physician as well, joining us from Wits University. Thanks very much for coming into the studio.